Good morning, Dr. Phil here. Today we'll be discussing on sedation, analgesia and paralysis for severe COVID-19 patients. Introduction. ARDS may complicate up to 42% of COVID-19 pneumonia cases. In patients with ARDS, moderate to deep levels of analgesia and sedation may be required to reduce respiratory drive in order to optimize their respiratory status. Neuromuscular blockers in ARDS facilitates patient ventilator synchrony. High demand for sedatives, analgesics and paralytics used in the care of COVID-19 patients requiring mechanical ventilation imparts pressure on the supply chain, worsening shortages of these medications, making utilization of more costly alternatives and unfamiliar medications likely. During surges of critical care patients, surge capacity and response is measured based on 3 levels: conventional care, contingency care, which are practices that may be outside usual care but they attempt to maintain usual care, and crisis care, which are practices that are outside of standard of care but provide the best feasible care when resources are severely limited. Strategies for alternative drug therapies and for preservation of existing medication supplies for the management of sedation, analgesia and paralysis in COVID-19 patients in the setting of drug shortages and patient surges should be employed. Level of sedation of ICU patients may be assessed by using sedation scales, such as the Richmond Agitation Sedation Scale or Riker Sedation Agitation Scale. Delirium can be assessed using the CAM ICU scoring method. The patient is CAM ICU positive, i.e. the patient has delirium, if RASS is -3 or more, and there is acute onset change in mental status or fluctuating course in mental status, and there are more than 2 errors in letter attention test, and either RASS is not 0 or combined number of errors to questions and commands exceeds 1. This is an algorithm to manage pain, agitation, and delirium in ICU in general by Reed MC et al. Determine whether there is a specific indication for sedation. If there is, for example, due to severe respiratory failure with or without neuromuscular blockade, status epilepticus or intracranial hypertension, first assess pain and treat with opioid or other drug or technique. If pain is controlled, target sedation to indication, for example, seizure control, acceptable intracranial pressure, tolerance of hypercarbia or necessary ventilator settings, and no awareness when being treated with neuromuscular blockers. Regularly assess the need for this level of sedation. The target sedation level is likely to be best communicated using the RASS scale. If there are no specific indications for sedation, assess pain and treat accordingly, then assess for delirium. If there is no delirium, assess the need for sedation and achieve a target RASS score of -2 to 0. If there is hypoactive delirium, treat with non-pharmacologic measures such as physical therapy, earplugs or quiet room, cognitive stimulation and repeated reorientation. Then assess the need for sedation to achieve a target RASS score of -2 to 0. If there is hyperactive delirium, treat with anti-delirium medications or non-pharmacologic measures. Then assess the need for sedation and target RASS score of -2 to 0. Reassess analgesic, anti-delirium and sedative requirements regularly, for example, every 4 hourly. Analgesia strategies in COVID-19 patients. Sources of pain in critically ill COVID-19 patients includes underlying respiratory disease, invasive procedures, endotracheal tube, mechanical ventilation, lines such as arterial, IV lines or chest tubes, proning or turning, physical therapy, tissue injury, for example, due to pressure sores, or from cardiovascular causes such as myocardial injury, and psychosocial causes. This table shows the analgesic options for COVID-19 patients. Examples includes fentanyl, which is a MOP receptor agonist, intermittent dosing 0.35 to 0.5 mcg per kg IV every half an hour to 1 hourly. Infusion is 0.7 to 10 mcg per kg per hour IV. Onset is 1 to 2 minutes. Duration is 30 to 60 minutes. Large volume of distribution of 4 to 6 liters per kg. Context sensitive half time 282 minutes at 8 hours continuous infusion. Elimination half-life of 2 to 4 hours. Fentanyl follows the three-compartment distribution model. Common adverse effects include chest wall rigidity with rapid infusion, place in therapy, first-line therapy, and conventional care. Patient care considerations. Prolonged and unpredictable clearance can extend beyond infusion discontinuation. The risk of hypotension is lower than morphine. There is accumulation in hepatic dysfunction. Fentanyl patch is an alternative, but consider absorption and efficacy issues, such as delayed onset and offset. Morphine is a MOP receptor agonist. The dose is 2 to 4 mg IV every 1 to 2 hourly. Infusion dose is 2 to 30 mg per hour IV. Onset is 15 to 30 minutes. Duration of action is 3 to 5 hours. Elimination half-life is 3 to 4 hours. Morphine is metabolized to morphine 6-glucuronide, which is active, and morphine 3-glucuronide, which is inactive. Examples of adverse effects include hypotension and bradycardia. It is first-line therapy and part of conventional care. The metabolite can accumulate in kidney dysfunction. Accumulation of morphine 6-glucuronide can cause sedation, and morphine 3-glucuronide can cause neurotoxicity. Enteromorphine is an alternative during a shortage, but IV to oral conversion needs to be considered for equipotent dosages. The next drug is hydromorphone, which is a MOP receptor agonist. The dose for intermittent dosing is 0.2 to 0.6 mg IV every 1 to 2 hours. Infusion dose is 0.5 to 3 mg per hour IV. Onset is 15 to 30 minutes. Duration of action is 3 to 4 hours. Elimination half-time is 2 to 3 hours. Hydromorphone is metabolized to hydromorphone 3-glucuronide, which is inactive. Hydromorphone can cause hypotension. It is part of first-line therapy and conventional care. Hydromorphone is 5 to 7 times more potent than morphine. Accumulation of hydromorphone 3-glucuronide in kidney dysfunction can cause neurotoxicity. Remifentanil is a MOP receptor agonist. Loading dose is 1.5 mcg per kg IV. Infusion dose is 0.5 to 15 mcg per kg per hour IV. Onset is 1 to 3 minutes. Offset is 5 to 10 minutes. Duration of action is 3 to 10 minutes. Terminal half-life is 10 to 20 minutes. Remifentanil is metabolized by blood and tissue esterases. Remifentanil can cause hypotension and chest wall rigidity. It is part of alternative therapy and contingency care. Monitor for opiate withdrawal symptoms for 24 hours after discontinuing remifentanil. Use actual body weight. Use ideal body weight if the patient's actual weight is more than 130% more than the ideal body weight. No accumulation occurs in hepatic or renal failure. Remifentanil can cause serotonin syndrome with concomitant use of serotonergic agents. Sufentanil is a MOP receptor agonist. The dose for infusion is 0.3 to 1.5 mcg per kg per hour. Onset for IV route is 1 to 3 minutes and sublingual route is 30 minutes. Duration of action for IV route is 2 hours and sublingual is 3 hours. Context-sensitive half-time is 30 minutes after 4-hour infusion. Terminal half-time is 2 to 3.5 hours. Sufentanil can cause bradyarrhythmia or hypotension. Sufentanil is part of alternative therapy and crisis care. Sufentanil can cause serotonin syndrome with concomitant use of serotonergic agents. Sufentanil is 5 to 10 times more potent than fentanyl. The enteral route is available as an alternative. However, note conversion for equipotent doses. The next drug is alfentanil. It is a MOP receptor agonist. Loading dose is 50 mcg per kg IV. Infusion dose is 0.5 to 1.5 mcg per kg per minute. Onset time for alfentanil is 1 minute. Duration of action is 30 to 60 minutes. Terminal half-life is 1.5 to 2 hours. Volume of distribution is 0.4 to 1 liters per kg. Context-sensitive half-time is 60 minutes after a 4-hour infusion. Alfentanil can cause hypotension. Alfentanil is part of alternative therapy and crisis care. Use actual body weight during dosing. Use ideal body weight if the patient's actual weight is 120% more than the ideal body weight. Alfentanil is 5 times more potent than fentanyl. Alfentanil has the potential to cause serotonin syndrome. The next drug is oxycodone, which is a MOP receptor agonist. Oral dose is 5 to 20 mg every 4 to 6 hourly. Onset is 10 to 15 minutes. Duration of action is 3 to 6 hours. Terminal half-life is 4 hours. Oxycodone can cause hypotension. Oxycodone is part of conservation and adjunct therapy and part of conventional care. Serum concentration increases by 50% in patients with creatinine clearance of 60 mL per minute. There is drug interaction with CYP3A4 inhibitors. Do not crush controlled release formulation. Be cautious with conversion to equipotent dosages. Methadone is a MOP receptor agonist and NMDA receptor antagonist. Oral dose for methadone is 10 to 40 mg every 6 to 12 hourly. Intermittent dosing is 2.5 to 10 mg IV every 8 to 12 hourly. Onset time for oral route is 0.5 to 1 hour. Onset time for IV route is 10 to 20 minutes. Duration of action is 12 to 48 hours. Half-life is 8 to 59 hours. Methadone reaches steady state in 3 to 5 days. Pharmacokinetics is affected by pharmacogenetics and repeated dosing. Methadone may cause QTc prolongation. Methadone is part of opioid conservation and adjunct therapy and contingency care. Methadone has long half-life. It has prolonged effect with hepatic and renal dysfunction. It may cause serotonin syndrome with concomitant use of serotonergic agents. Elimination half-life does not match the short duration of analgesic effect. Caution when co-administrating with other QTc prolonging agents. Gabapentin. It works by calcium channel modulation. Oral dose is 900 to 3600 mg per day divided into 3 to 4 doses. Gabapentin has slow onset of action. Peak plasma concentrations occur within 2 to 3 hours. Half-life is 6 hours. Gabapentin is renally eliminated. Gabapentin can cause occasional peripheral edema. It is part of opioid conservation and adjunct therapy and conventional care. Reduced dose based on creatinine clearance. Carbamazepine is a sodium channel inhibitor. The dose is 200 to 1200 mg per day divided into 2 to 3 doses. Peak effect occurs in 4 to 8 hours. It undergoes hepatic metabolism to carbamazepine 1011 epoxide, which is active. Half-life is 24 hours. It is a major CYP3A4 substrate and also a CYP2C19 and 3A4 inducer. Carbamazepine may cause dose-dependent hyponatremia, transient elevation of hepatic transaminases, and Stevens-Johnson syndrome. Carbamazepine is part of opioid conservation and adjunct therapy and conventional care. Consider 25% dose reduction in severe renal impairment, creatinine clearance less than 10 mL per minute. Consider dose reduction as it undergoes extensive hepatic metabolism to produce active metabolites. Pregabalin is a calcium channel modulator. Oral dose is 150 to 600 mg per day divided into 3 to 4 doses. Pregabalin has slow onset of action. Pregabalin reaches peak plasma concentrations within 1.5 hours and achieves steady state within 24 to 48 hours. Half-life is 6 hours. Pregabalin is renally eliminated. Pregabalin can cause occasional peripheral edema. Pregabalin is part of opioid conservation and adjunct therapy and conventional care. Reduced dose based on creatinine clearance. Ketorolac is an NSAID that reversibly inhibits COX-1 and 2 enzymes. Intermittent dose is 15 to 30 mg IV or IM every 6 hourly, up to 5 days. Onset is 30 minutes. Half-life is 2 to 9 hours. Ketorolac is renally eliminated. Ketorolac can cause kidney injury and bleeding and is part of opioid conservation and adjunct therapy and crisis care. Avoid NSAIDs in renal dysfunction, GI bleed, and platelet abnormalities. Ibuprofen is an NSAID that causes reversible inhibition of COX-1 and 2 enzymes. Oral dose is 400 mg every 4 hourly, maximum 2.4 grams per day. Intermittent dose is 400 to 800 mg IV every 6 hourly, maximum 3.2 grams per day. Onset of action for oral route is 30 minutes. Half-life is 2 to 3 hours. Ibuprofen is renally eliminated. There is risk of kidney injury and bleeding with ibuprofen use. It is part of opioid conservation and adjunct therapy and crisis care. Avoid NSAIDs in renal dysfunction, GI bleed, and platelet dysfunction. Lidocaine is a sodium channel blocker. Loading dose is 1.5 mg per kg. Infusion dose is 0.5 to 2.5 mg per kg per hour. Onset time is 45 to 90 seconds. It is metabolized in the liver to active metabolite monoethyl glycine xylidide, and glycine xylidide. Half-life is biphasic, initially 7 to 30 minutes, terminal half-life is 1.5 to 2 hours. Lidocaine is renally eliminated. Potential adverse effects include bradycardia, hypotension, blurred vision, tremors and seizures. Lidocaine is part of opioid conservation and adjunct therapy and crisis care. Monitor drug levels, and it normally should be less than 4 mcg per ml. Toxic level occurs when lidocaine exceeds 5 mcg per ml. The half-life prolongs with congestive heart failure, liver disease, shock and renal impairment. Recommended therapies for analgesia in COVID-19 patients. Commonly used IV analgesics in mechanically ventilated patients includes morphine, fentanyl, and hydromorphone. Morphine has been discussed in the above table. Fentanyl is the most commonly used synthetic opioid for analgesia in conventional care due to its distinctive pharmacokinetics. Continuous infusions of fentanyl may lead to prolonged and unpredictable clearance that can extend beyond infusion discontinuation. Rapid IV fentanyl infusion has been associated with chest wall rigidity, potentially reducing chest wall compliance, causing inadequate spontaneous ventilation, and challenges in utilizing assisted ventilation. Hydromorphone is an appropriate alternative to fentanyl and morphine and is associated with medication errors due to its potency, and if errors occur, they are likely to be overdoses. Kindly refer to the videos discussing opioids for further details for their pharmacology. Alternative therapies for analgesia in COVID-19 patients includes remifentanil, sufentanil, and alfentanil. Remifentanil is a selective MOP receptor agonist. Pharmacodynamic properties are similar to that of fentanyl. It's an alternative to fentanyl for analgesia and should be considered in contingency care. Remifentanil has been associated with higher incidence of hypotension compared with fentanyl. Unlike fentanyl, remifentanil is rapidly metabolized by blood and tissue esterases, resulting in very short duration of action, independent of the duration of infusion. Due to the short half-life of remifentanil, ensure adequate pain management prior to discontinuation to prevent withdrawal symptoms. A study by Moelejans et al., which is a multi-center double-blind randomized control trial that included mixed ICU mechanically ventilated patients which compared the efficacy and safety of remifentanil versus fentanyl for sedation and analgesia, reported no difference in time spent in optimal sedation level during fentanyl or remifentanil infusion. Patients who received remifentanil exhibited significantly less between patient variability in optimal sedation compared to fentanyl. Patients receiving remifentanil experienced pain significantly longer during extubation, post-extubation, and post-treatment due to its rapid onset. There were no differences in hemodynamic instability or adverse effects. Sufentanil and alfentanil are ultra-short-acting opioids not commonly used in the ICU and may be options in the setting of severe drug shortages and crisis care. They are 5 to 10 times more potent than fentanyl, thus they can conserve fentanyl infusion volume and dose requirements. Sufentanil is also available as sublingual tablets with 53% bioavailability. Sublingual sufentanil blunts the rapid increase in serum sufentanil levels seen with the IV route and reduces the risk of adverse events with high-dose IV sufentanil. Kindly refer to the videos discussing opioids for further details. Conservation strategies for analgesia in COVID-19 patients. Implement protocols where clinicians would initially utilize intermittent IV bolus analgesic doses prior to transitioning patients to continuous infusion of analgesia. Secondly, provide opioids and analgesics enterally to assist with conserving supply of IV agents. This is limited to patients with adequate GI motility and function, as opioids have equivalent analgesic properties without significant difference in outcomes. Supplementing IVI opioid with equianalgesic doses of enterooxycodone or morphine is reasonable. Examples of enteroopioids include oxycodone, morphine, and methadone. Controlled release enteroopioids has a fairly rapid onset of action and a prolonged and constant duration of action. Examples include controlled release oxycodone. These types of medications should not be crushed and administered through a feeding tube and are reserved for COVID-19 patients who are able to swallow. Enteromethadone. Methadone has a long half-life. Half-life does not match the duration of analgesia, which is 6 to 12 hours, which can lead to drug accumulation with rapid titration. Well-established protocols for conversion to enteromethadone should be used. Enteromethadone can be used to substitute patients' IV opioids requirements in contingency care. Example of dosage is 10 mg every 6 hourly. Enteromethadone reduces IVI fentanyl requirements in mechanically ventilated critically ill patients. The dose for enteromethadone may be increased, for example by 50%, in patients who exhibit opioid withdrawal intolerance. Enteromethadone has the risk of prolonging QTC interval. Close monitoring of QTC interval is required. Transdermal fentanyl patches. This is not recommended for acute pain management as it takes 12 to 16 hours after patch application to achieve therapeutic fentanyl blood concentrations. Pharmacokinetics of absorption is not predictable as it is affected by site of patch application and body temperature. Fentanyl patches can be a reasonable option for non-opioid naive patients receiving opioid continuous infusions for several days in contingency care in the setting of opioid drug shortages. Transition guides from continuous infusion to transdermal patch have been evaluated with recommendations to overlap the infusion and fentanyl patch and reduce infusion dose within 6 to 12 hours. Multimodal analgesia approach might facilitate better pain control and reduce patients' opioid requirements. The 2018 Clinical Practice Guidelines for the Prevention and Management of Pain, Agitation, Sedation, Delirium, Immobility, and Sleep Disruption in Adult Patients in ICU, PADIS, suggest using the following opioid adjuncts to reduce pain and opioid use in critically ill patients: paracetamol, ketamine, gabapentin, carbamazepine, and pregabalin. These opioid adjuncts facilitate providing adequate analgesia in the setting of opioid drug shortages and in contingency care. The 2018 PADIS guidelines do not recommend the routine use of NSAIDs due to risk of GI bleed and kidney injury, or IV lidocaine due to lack of quality evidence for pain management in the critically ill. In the setting of extreme drug shortages, NSAIDs and IV lidocaine can play a role as adjunct therapies in the appropriate patient population with no hepatic and renal dysfunction and at lower risk for adverse events. Sedation strategies in COVID-19 patients. Currently, there are no guidelines available for managing sedation in COVID-19 patients requiring mechanical ventilation. However, the 2018 PADIS guidelines for sedation in critically ill patients still pertains. Light sedation over deep sedation is recommended. However, although light sedation is recommended, COVID-19 associated pneumonia and ARDS may require moderate to deep levels of sedation to optimize the patient's respiratory status. Emphasize on an analgo sedation or an analgesia before sedation approach. Use non-benzodiazepine sedatives such as propofol or dexmedetomidine. This table shows the sedative options for COVID-19 patients. Propofol is a GABA agonist. The dose for infusion is 5 to 50 mcg per kg per minute. Onset time is 30 seconds. Initial distribution half-life alpha is 2 to 3 minutes. Beta 1 half-life is 30 to 60 minutes. Terminal half-life for short-term use is 3 to 12 hours and long-term use 50 plus minus 18.6 hours. Contact-sensitive half-life for a 2-hour infusion is 16 minutes. Contact-sensitive half-life for an 8-hour infusion is 41 minutes. Duration of action is 3 to 10 minutes but increases with increasing time of infusion. Propofol has a large volume of distribution of 2 to 10 liters per kg. Propofol is highly protein-bound, 98%, and is highly lipophilic. Metabolism is primarily hepatic with production of sulfate and glucuronide conjugates and other inactive metabolites. Kidneys excrete metabolites, mainly glucuronides, into the urine. 0.3% is excreted unchanged. Adverse events include propofol-related infusion syndrome, respiratory depression, hypertriglyceridemia, cardiovascular depression and hypotension, risk of awareness during underdosing, pain on propofol injection, and rarely anaphylaxis. Propofol is the first-line agent for light or deep sedation. It may be reserved for deep sedation if there are drug shortages. It is part of conventional care. Utilize alternative agents if triglycerides exceed 800 mg per dl. Midazolam is a GABA agonist. Infusion dose is 0.02 to 0.1 mg per kg per hour. Intermittent dose is 0.5 to 4 mg IV bolus doses every 15 minutes to 1 hour as needed. Onset time is 3 to 5 minutes. Midazolam has a large volume of distribution of 1 to 3 liters per kg. Half-life is 3 to 11 hours and is prolonged in obese patients. Midazolam undergoes hepatic metabolism to produce an active metabolite, alpha-hydroxymidazolam, which accumulates in renal failure. Potential adverse effects include respiratory and cardiovascular depression, especially in elderly and sick patients in whom reduced dosage is required. Anterograde amnesia can occur. Midazolam is an alternative therapy for deep sedation and part of contingency care. Caution with use in obese patients and those with renal failure due to drug accumulation. Midazolam can be used as intermittent doses for intermittent agitation or sedation. Oral doses can be used to wean off continuous infusion. Lorazepam is a GABA agonist. Infusion dose is 0.01 to 0.1 mg per kg per hour. Intermittent dose is 0.5 to 4 mg every 2 to 6 hourly as needed, via oral or IV route. Onset time is 3 minutes. Half-life is 8 to 15 hours. Lorazepam produces inactive metabolites. Duration of action is 6 to 8 hours. Potential adverse effects include respiratory depression and propylene glycol toxicity with IV use. Lorazepam is part of alternative therapy for deep sedation and contingency care. Lorazepam may be preferred to midazolam in obesity and renal failure. Monitor for development of propylene glycol toxicity. Lorazepam can be used as intermittent doses for intermittent sedation requirements. Oral doses can be used to wean off continuous infusions. Diazepam is a GABA agonist. Intermittent dosing is 2 to 10 mg every 3 to 6 hourly as needed via oral or IV route. Onset time is 3 minutes. Diazepam is metabolized to multiple active metabolites, including nordiazepam, desmethyldiazepam, oxazepam, and temazepam. Half-life is about 40 hours for the parent compound and up to 100 hours for the metabolite. Diazepam can cause respiratory depression and propylene glycol toxicity with IV use. Reduced cardiac output and vasodilation can occur with large doses. Drowsiness and confusion can occur and may persist for several hours. Diazepam is part of alternative therapy for light sedation in intermittent doses and contingency care. It is a long-acting intermittent dose agent and can be used as intermittent doses for intermittent sedation requirements. Oral doses can be used to wean off continuous infusions of sedatives. Dexmedetomidine is an alpha-2 adrenoceptor agonist in the brainstem that mediates sedation through the locus coeruleus. Dexmedetomidine has about 1,300 to 1,600 times the affinity for alpha-2 receptors as for alpha-1. Loading dose is optional, 1 mcg per kg over 10 minutes. Infusion dose is 0.2 to 1.5 mcg per kg per hour. Doses exceeding 1.5 mcg per kg per hour are unlikely to add any clinical benefit. Onset time is 5 to 10 minutes after loading doses and 18 to 30 minutes with no loading dose. Half-life is 2 to 3 hours. Volume of distribution is about 1.3 liters per kg. It is 94% protein bound. Dexmedetomidine is inactivated mainly in the liver to glucuronides, with 80 to 90% excreted in the urine. Dexmedetomidine accumulates with hepatic failure. Duration of action is 60 to 120 minutes. Dexmedetomidine may cause bradycardia, decreased cardiac output, hypotension, and hypertension with bolus dosing or high infusion rates. Dexmedetomidine is first-line agent for light sedation and is part of conventional care. It may be used for weaning mechanical ventilation. It is an adjunct to reduce or conserve opioids. Dexmedetomidine cannot provide deep sedation. It does not cause respiratory depression. It has analgesic and opioid-sparing effects. The next drug is ketamine. It is a non-competitive NMDA receptor antagonist. The dose for infusion, light sedation or analgesia is 0.1 to 1 mg per kg per hour. For deep sedation, the dose is more than 1 mg per kg per hour.
The onset time for IV route is 1 to 2 minutes, and for IM route is 10 to 15 minutes. Ketamine is very lipid soluble and weakly protein bound at 12%.
Half-life alpha is 5 to 17 minutes, half-life beta is 2.5 hours, and is prolonged in critically ill patients up to 5 hours. Volume of distribution increases threefold in the critically ill. Duration of action is dose and duration dependent, and lasts 15 minutes to 1 hour, and is prolonged in renal or hepatic dysfunction. Ketamine is metabolized
In the liver,
to norketamine, which is 33% as potent as the parent compound, dihydronorketamine, hydroxyketamine, and hydroxynorketamine.
80% is excreted as glucuronides in the urine, 2.5% is excreted unchanged.
Potential adverse effects of ketamine includes hypersalivation, hypertension and tachycardia, hypotension and decreased cardiac output in the critically ill, psychotomimetic effects,
And raised ICP.
Monitor for myocarditis in COVID-19 patients. Ketamine is a second-line agent for sedation for light or deep sedation and part of contingency care. It is an adjunct to reduce or conserve opioids. It can be used for weaning mechanical ventilation at low doses. Ketamine preserves pharyngeal and laryngeal protective reflexes. It lowers airway resistance and increases lung compliance. Ketamine has analgesic and opioid-sparing effects. Ketamine can be concentrated to 10 mg per ml to minimize volume. Patients should be monitored on continuous telemetry. The next drug is pentobarbital. This drug binds directly to the GABA A receptor, exerting its effects in the presence or absence of endogenous GABA. The dose for seizures or medically induced coma, loading dose is 5 to 15 mg per kg, infusion dose is 0.5 to 5 mg per kg per hour. Dosing for sedation is likely to be less. Consider initiating doses at 50% less than what would be used for coma. Onset time is 3 to 5 minutes. Half-life is 15 to 50 hours. Duration of action is 15 to 45 minutes. Pentobarbital accumulates in severe hepatic failure. Pentobarbital can cause respiratory depression, hypotension, decreased myocardial contractility, hypothermia, and propylene glycol toxicity. Pentobarbital is a vesicant. It is last line in extreme drug shortages and part of crisis care. Pentobarbital decreases ICP. Therapeutic serum levels are unnecessary if being used for sedation. Pentobarbital is often confused with phenobarbital. Volatile anesthetic agents. These drugs alter the activity of neuronal ion channels, particularly the fast synaptic neurotransmitter receptors, nicotinic, acetylcholine, GABA, and glutamate. The dose is based on minimal alveolar concentration.
MAC may be targeted from 0.5 to 1.2 titrated to level of desired sedation.
Volatile gases causes rapid onset and offset of action. Clearance is independent of hepatic and renal function. Volatile agents produces no metabolites. Potential adverse effects includes malignant hyperthermia, cerebral vasodilation,
Respiratory depression.
hypotension, and nausea and vomiting. Volatile agents are reserved as last-line therapy in extreme drug shortages or crisis care. It is ideally used for short periods of time to get the patient to more definitive therapy such as ECMO. Data for use over 54 hours is severely limited. Volatile anesthetic agents are shown to cause pharmacologic pre- and post-conditioning of the myocardium. Development of dependence or tachyphylaxis do not occur with volatile anesthetics. Phenobarbital is a sedative that binds directly to GABA A receptor, exerting its effects in the presence or absence of endogenous GABA. The dose for sedation is 200 mg every 6 to 8 hours or 7.5 mg per kg IV loading dose, followed by 1 to 2 mg per kg per day, divided every 12 hourly. For sedative withdrawal, the dose is 200 mg followed by 100 mg every 4 hourly for 5 doses, 60 mg every 4 hourly for 4 doses, then 60 mg every 8 hourly for 3 doses. The onset time via oral route is 60 minutes and via IV route is 5 minutes. Half-life is 53 to 118 hours. Duration of action for oral route is 10 to 12 hours. For IV route is 6 hours. Bioavailability is 95% or more. Phenobarbital is metabolized via oxidation through CYP2C9. Phenobarbital is an inducer of CYP3A4 and CYP2C. Phenobarbital can potentially cause respiratory depression, hypotension, hepatotoxicity, laryngospasm with rapid IV administration, and propylene glycol toxicity. Phenobarbital may be used as a primary or adjunctive agent to enhance or wean sedation and during crisis care. It can be used to treat alcohol withdrawal and seizures, monitor for drug interactions. The ratio for oral to IV conversion is 1:1. Tapering is not always necessary when given for a short period of time. Clonidine is an alpha-2 adrenoceptor agonist in the brainstem that mediates sedation through the locus ceruleus. Oral dose is 0.3 to 1.6 mg per day, divided into 3 to 4 doses. For transitioning off dexmedetomidine, the dose is 0.2 to 0.5 mg every 6 hourly. Taper clonidine every 24 to 48 hours by increasing dosing frequency and reducing dexmedetomidine infusion by 25% within 6 hours of each clonidine dose. Onset of action for oral route is 0.5 to 1 hour. Half-life is about 12 hours in healthy patients and is prolonged to 40 hours in patients with renal dysfunction. Hepatic metabolism of clonidine occurs through CYP2D6. Clonidine may cause hypotension, bradycardia, and xerostomia. Clonidine is an adjunctive agent to enhance or wean sedation, particularly if the patient is on dexmedetomidine, and is part of conventional care. Clonidine has opioid-sparing effects. Taper off if used for prolonged periods. Ketamine and propofol can be combined into ketofol. This table shows how to dilute this drug. Withdraw 4 ml of ketamine, 50 mg per ml concentration, and dilute with 16 ml of normal saline to make up a volume of 20 ml. Draw out all solution and mix with 1 ampule of propofol 1%. The final volume is 40 ml. Final concentration is ketamine 5 mg per ml and propofol 5 mg per ml. This is stable for 6 hours at room temperature. The dose is 0.1 to 0.5 mg per kg bolus, followed by 0.2 to 0.5 mg per kg per hour, maximum up to 2.5 mg per kg per hour. No dosage adjustment is required for renal or hepatic impairment. This table is used to guide the IV infusion rate for ketofol 5 mg per ml in mL per hour based on the dose and the weight of the patient. Light sedation. Recommended therapies for light sedation in COVID-19 patients includes propofol and dexmedetomidine. Propofol is often utilized for patients who require light sedation. Due to shortages, it may be reasonable to limit propofol use to those who require deep sedation. Dexmedetomidine should be recommended as sedative of choice when there are no contraindications, such as bradycardia, for light sedation in ICU patients. Dexmedetomidine has been shown to reduce the incidence of ICU delirium. It has opioid-sparing effects and may help conserve analgesic agents. Withdrawal effects may be more problematic in COVID-19 patients who are known to require sedation for prolonged periods of time. Peak doses greater than 0.8 mcg per kg per hour and cumulative daily doses greater than 12.9 mcg per kg per day are associated with a higher incidence of withdrawal. Withdrawal effects may be ameliorated with the use of clonidine. Alternative therapies for light sedation in COVID-19 patients includes ketamine and benzodiazepines. Ketamine has been utilized to achieve light sedation for decades and can be considered as an alternative therapy in the setting of contingency care scenarios in the setting of drug shortages. Ketamine has analgesic properties which may help conservation of IV opioids. It is not known to cause significant respiratory depression at moderate doses. This can be an advantage when trying to liberate a patient from mechanical ventilation. Benzodiazepines should only be considered as first-line option sedative in settings of contingency care scenarios due to the improved benefit and better side effect profile of non-benzodiazepine sedatives. Benzos can be administered as intermittent doses or as a continuous infusion to achieve light sedation. Benefits of intermittent doses includes: it conserves drug supplies in the setting of ongoing shortages, it limits overall exposure to sedatives, it provides appropriate light sedation, and conserves a need for high doses and continuous infusions where accumulation can occur. Examples of benzos that can be administered intermittently includes lorazepam, midazolam, or diazepam. If intermittent or as-needed doses is not sufficient to provide adequate sedation, continuous infusion of lorazepam or midazolam can be initiated. Intermittent doses can be reconsidered again when continuous infusion is no longer necessary, and transitioning from continuous infusion to a less aggressive dosing regimen is appropriate. Nurse protocolized targeted sedation should be used in an effort to minimize oversedation. Oral benzodiazepines such as lorazepam or diazepam can be utilized to wean off continuous infusion sedatives. Deep sedation. Recommended therapies for deep sedation includes propofol and benzodiazepines. Propofol is often thought as the preferred sedative in conventional care to provide deep sedation due to its rapid action and quick elimination. Propofol can cause hypertriglyceridemia as it is a 10% fat emulsion containing product. Alternative agents should be utilized in patients with elevated triglycerides, more than 500 mg per dl, to prevent pancreatitis. About 10% of patients with hypertriglyceridemia had pancreatitis, and these patients had serum triglyceride concentrations of 1000 mg per dl or more. Patients with Covid-19 can present with a picture similar to a secondary hemophagocytic lymphohistiocytosis (HLH) with hypertriglyceridemia. HLH is a severe systemic inflammation syndrome due to absence of downregulation of activated macrophages and lymphocytes. Thus, triglyceride concentrations should be monitored frequently, every 24 to 48 hours in patients with Covid-19 who are receiving propofol, as Covid-19 patients may already present with elevated triglycerides not due to propofol. It is reasonable to have a more liberal cutoff to consider alternative agents once the triglycerides reach 800 mg per dl. Propofol-related infusion syndrome. This is a potentially fatal adverse effect of propofol. Overall incidence is around 1.1%. In severe cases, it is characterized by hyperlipidemia, profound metabolic acidosis, and rhabdomyolysis, which can lead to renal and cardiac failure. The syndrome may be due to the effects on mitochondria, either by direct inhibition of the respiratory chain of oxidative phosphorylation or by compromising mitochondrial metabolism of free fatty acids. This remains unproven. Risk factors include dosage exceeding 4 mg per kg per hour for more than 48 hours, acute neurological injury, catecholamine infusion, corticosteroid infusion, and low carbohydrate intake. It is recommended that infusions should be limited to no more than a rate of 4 mg per kg per hour, although this does not eliminate the risk of the syndrome. Treatment is to discontinue propofol infusion, provide supportive care, and switch to other sedatives such as midamorphine or midafentanyl. Benzodiazepines. If propofol is unavailable or contraindicated, IVI benzodiazepines remains a good alternative for deep sedation. Benzos have demonstrated safety in various patient populations, balanced against the risk of prolonged ICU length of stay, duration of mechanical ventilation, and ICU delirium. Alternative therapies for deep sedation in COVID-19 patients includes ketamine, pentobarbital, volatile anesthetic agents, and the usage of concomitant agents such as phenobarbital, clonidine, haloperidol, and atypical antipsychotics. Ketamine. Ketamine may be an attractive alternative for patients with COVID-19 requiring deep sedation due to its dissociative anesthetic properties and benefits on the respiratory system. As an adjunctive sedative, addition of ketamine enables concomitant sedatives such as propofol or benzodiazepines to be reduced or discontinued. Ketamine causes increased respiratory secretions, which may lead to laryngospasm, or clogging of the endotracheal tube, resulting in a need for aggressive suctioning. Hypersalivation can be treated with glycopyrrolate or sublingual atropine. Ketamine may cause hallucination and psychosis, and this may be related to dose escalations. These symptoms are ameliorated by benzodiazepines. Ketamine is associated with raised ICP. Ketamine acts as a sympathomimetic by facilitating adrenergic transmission and inhibiting catecholamine reuptake. In critically ill septic shock patients, ketamine may cause profound hypotension and reduce cardiac performance, likely due to volume and catecholamine depletion. Use with caution in patients with cardiac dysfunction, as ketamine may cause reduced cardiac output, increased pulmonary capillary wedge pressure, and increased systemic vascular resistance. Development of myocarditis has been documented in patients with COVID-19. Although there are no data suggesting ketamine increases the risk of myocardial collapse, close monitoring of cardiac function is warranted. Due to lack of data and adverse effect profile, ketamine should be reserved for contingency care situations when conventional therapies are in short supply. Pentobarbital. This drug is used primarily for refractory status epilepticus and for medically induced coma. Data surrounding its use as a sedative in mechanically ventilated patients is limited to the pediatric population. Dosing for sedation is likely to be less than doses utilized for medically induced coma. Pentobarbital can be titrated to goal sedation levels. Volatile anesthetic agents. These gases are primarily used for general anesthesia in patients undergoing surgery. Examples include isoflurane, sevoflurane, and desflurane. Isoflurane depresses ventilation and reduces airway resistance. It reduces cardiac output, SVR, MAP, and increases heart rate. Isoflurane causes minimal reduction in hepatic blood flow. Isoflurane is more resistant to defluorination and can be used for prolonged periods without significant increases in serum fluoride levels. Sevoflurane depresses ventilation and reduces airway resistance. It reduces cardiac output, SVR, MAP. It has minimal effect on heart rate. Sevoflurane undergoes significant defluorination. However, sevoflurane has not been proven to increase the risk of kidney injury. Desflurane depresses ventilation. It has minimal effect on airway resistance. It reduces cardiac output, SVR, MAP. It causes increased heart rate. Desflurane causes minimal reduction in hepatic blood flow. Desflurane is not significantly defluorinated. Sevoflurane may improve PaO2 to FiO2 ratio in ARDS patients. Use of volatile gases is limited by the requirement of extensive bedside equipment, unfamiliarity with these agents outside of the operation theatre, and lack of data for long-term sedation. Clinical considerations when administering volatile agents. They can cause respiratory depression and cardiovascular depression. They can cause malignant hyperthermia, albeit rarely. They can cause dose-dependent cerebral vasodilation. Sevoflurane has been shown to reduce blood pressure and cerebral perfusion pressure in patients with acute or subarachnoid hemorrhage. A minimal tidal volume of 350 ml is recommended to overcome device dead space when using volatile agents. The use of pentobarbital and volatile agents for sedation in ICU patients should be reserved for profound drug shortages in crisis care scenarios due to lack of efficacy and safety data with their long-term use. Concomitant agents are available to enhance or wean off long-term sedation. Examples include phenobarbital, clonidine, haloperidol, and atypical antipsychotics. Phenobarbital. This may be an effective agent in maintaining sedation and comfort in ICU patients. It can be combined with fentanyl. For example, fentanyl infusion plus boluses of phenobarbital 200 mg every 6 to 8 hourly. Phenobarbital could be utilized as a primary sedative or in an effort to wean off sedation. It may be an effective agent in patients who are refractory to traditional sedatives or for those requiring long-term sedation. A dosage example includes 7.5 mg per kg IV loading dose of phenobarbital followed by 1 to 2 mg per kg per day IV or enterally divided every 12 hourly with additional IV doses given hourly for breakthrough agitation. Due to its long half-life, tapering is not generally necessary when given for a short period of time. Enteral or IV bolus dosing may be advantageous in fluid-restricted patients. Due to paucity of data, phenobarbital is best utilized during contingency care scenarios when conventional resources are limited. Clonidine. This has been utilized for management of agitation and pain due to its activity on the central nervous system.
Clonidine is an agonist at alpha-2 adrenoceptors. It has some minor activity at alpha-1 receptors, with a ratio of alpha-1 to alpha-2 action as 1 to 200. It also acts on imidazole receptors.
It causes reduction in sympathetic outflow and may cause hypotension. Thus, it may not be suitable for patients with hemodynamic instability. Blood pressure response to clonidine may follow a U-shaped curve, likely due to loss of alpha-2 adrenoceptor specificity at higher doses, resulting in peripheral alpha-1 adrenoceptor stimulation and vasoconstriction. Clonidine reduces daily requirements of opioids and benzodiazepines and enables discontinuation of concomitant sedatives, for example, during transitioning from dexmedetomidine. Haloperidol and atypical antipsychotics. These drugs work through antagonism at various neurotransmitter receptors in the brain. It is used in the ICU for treatment of significant distress secondary to symptoms of delirium and as adjunctive treatment to reduce agitation in ICU patients. They are not capable of providing adequate sedation on their own. Long-term adverse effects are reduced by short-term use. Examples of adverse effects include arrhythmias, prolonged QTC, serotonin syndrome, neuroleptic malignant syndrome, extrapyramidal symptoms, and rhabdomyolysis. Inadvertent continuation of therapy should be monitored. Conservation strategies for sedatives in COVID-19 patients. Prime propofol lines with 20 ml propofol vials rather than using the 100 ml vials to conserve propofol supply, to decrease frequent entry to COVID-19 patient rooms. 20 ml vials of propofol are often utilized for IV push doses. Propofol is formulated as a nutrient-rich emulsion, and it is recommended that propofol vials and lines be changed every 12 hours to minimize risk of bloodstream infections. Some institutions may change vials and lines more frequently. Propofol supply and extension tubing can be conserved by extending tubing replacement to every 12 hours. There are no safety data that indicates it is safe to extend propofol vial use and line exchanges beyond 12 hours. Daily awakening trials. This includes those requiring deep sedation. Daily awakening trials should be done during all levels of surge capacity to conserve medication supplies and improve patient outcomes. Daily awakening trials are associated with reduced duration of mechanical ventilation, reduction in ICU length of stay, and reduction in sedative requirements. Force a reassessment of patients' sedation needs to reduce sedation administration, conserving drug supply, and minimizing overall exposure to sedatives. Awakening trials should not be conducted in patients receiving neuromuscular blockers. Another strategy to conserve sedatives includes to reduce the maximum dose allowed on the titrated range for sedation orders and supplementing with adjunct sedatives to target adequate levels of sedation. Paralysis strategies in COVID-19 patients. Benefits of neuromuscular blockers in ARDS includes improvement in chest wall compliance, reduction in patient ventilator desynchrony, facilitation of lung recruitment, and reduction in inflammatory response of ARDS. Options for neuromuscular blockers for COVID-19 patients. Examples include atracurium, cisatracurium, pancuronium, rocuronium, and vacuronium. Atracurium is a non-depolarizing neuromuscular blocker. It is intermediate acting. The dose is bolus 0.4 to 0.5 mg per kg. Infusion dose is 5 to 20 mcg per kg per minute. Onset time is 3 to 5 minutes. Initial half-life is 2 minutes. Terminal half-life is 20 minutes. Duration of action is 20 to 35 minutes. It is eliminated by the Hoffman reaction. Examples of adverse effects include histamine release and hypotension, and production of laudanosine metabolite, which may cause flushing or seizures. It is an alternative agent for use during continuous infusions and is used during contingency care. Hypotension may occur with rapid administration. Duration of action is not affected by renal or hepatic dysfunction. Cis-atracurium is a non-depolarizing neuromuscular blocker. It is intermediate acting. For intermittent dosing, the dose is 0.1 to 0.2 mg per kg boluses. Infusion dose is 1 to 4 mcg per kg per minute. Fixed dose infusion is 37.5 mg per hour. Onset time is 2 to 3 minutes. Half-life is 22 to 29 minutes. Duration of action is 30 to 60 minutes. Cis-atracurium is eliminated via the Hoffman reaction. Cis-atracurium may rarely cause bronchospasm or bradycardia. Cis-atracurium is first line for continuous infusions and is used during conventional care. It is the most commonly studied neuromuscular blocker in ARDS. Duration of action is not affected by renal or hepatic dysfunction. Pancuronium is a non-depolarizing neuromuscular blocker. It is long-acting. The intermittent dosing is boluses of 0.05 to 0.1 mg per kg. Infusion dose is 0.8 to 1.7 mcg per kg per minute. Onset time is 2 to 3 minutes. Half-life is 89 to 161 minutes. Duration of action is 60 to 100 minutes. Elimination is 45 to 70% renal and 15% hepatic. Pancuronium has active metabolites. Pancuronium may cause vagal blockade or sympathetic stimulation, producing hypertension or tachycardia. Pancuronium is an alternative for intermittent boluses and is used during crisis care. Monitoring of pupillary reflexes are unreliable due to its anti-muscarinic effects. Rocuronium is a non-depolarizing neuromuscular blocker. It is intermediately acting. Intermittent dosing is boluses of 0.6 to 1.2 mg per kg. Infusion dose is 8 to 12 mcg per kg per minute. Onset of action is 1 to 2 minutes. Half-life alpha is 1 to 2 minutes. Beta half-life is 1 to 2 hours. Duration of action is 20 to 35 minutes. 33% is eliminated renally. Less than 75% is eliminated hepatically. Rocuronium may cause vagal blockade at higher doses. It is used during intermittent boluses and is part of conventional care. It is second line for continuous infusion, and for continuous infusion it is part of contingency care. It is preferred in renal dysfunction over vecuronium. Vecuronium is a non-depolarizing neuromuscular blocker. It is intermediately acting. Intermittent dosing is boluses of 0.1 mg per kg. Infusion dose is 0.8 to 1.7 mcg per kg per minute. Onset time is 3 to 4 minutes. Distribution half-life is 4 minutes. Duration of action is 20 to 45 minutes. 10 to 50% is eliminated renally, and 35 to 50% is eliminated hepatically. Vecuronium's active metabolite is 3-desacetylvecuronium, which is renally eliminated. Vecuronium may cause vagal blockade at higher doses. Intermittent boluses is part of conventional care. And for continuous infusions, it is part of contingency care. It is preferred in hepatic dysfunction over rocuronium. Recommended therapies for paralytics in COVID-19 patients. Cis-atracurium is the only neuromuscular blocker that has been studied in randomized controlled trials. Centers that use cis-atracurium for continuous infusion neuromuscular blockers may need to consider alternative drugs due to shortages. It is unknown if the benefit is confined to cis-atracurium, although one single-center retrospective study that compared atracurium to cis-atracurium for severe ARDS found no differences in clinical outcomes. Two randomized controlled trials, Accuracis and ROSE, evaluated neuromuscular blocking agents for the use in early, moderate to severe ARDS with a PaO2 to FiO2 ratio of less than 150 mmHg and used cis-atracurium as a continuous infusion at a rate of 37.5 mg per hour for 48 hours. These trials did not utilize peripheral nerve stimulators or train of 4 to monitor depth of paralysis. All patients in the NMBA arms received deep sedation prior to the initiation of neuromuscular blockers and did not utilize monitors for sedation such as BIS monitors. These studies had inconsistent results for mortality rates and adverse effects of neuromuscular blockers. Based on the results of both studies, the role of continuous infusion neuromuscular blockers in moderate to severe ARDS has diminished, and the use is limited to patients with ventilator dysynchrony or refractory hypoxemia. Alternative therapies for neuromuscular blockers in COVID-19 patients includes atracurium, rocuronium, vecuronium, and pancuronium. Atracurium, rocuronium, and vecuronium can be used as continuous infusions and should be considered during contingency care. Pancuronium is a long-acting neuromuscular blocker and can be considered for continuous infusions during crisis care. It should be used with an understanding of its adverse effects. Its vagolytic effects can increase heart rate and blood pressure due to increased release and reduced reuptake of catecholamines at adrenergic nerve terminals. Give an equivalent dose to achieve the same therapeutic effect based on TOF assessment when switching from one agent to another. It is important to consider that rocuronium and vecuronium have renal and hepatic elimination. Unlike atracurium and cis-atracurium, which undergo Hoffman elimination, thus these agents may have prolonged elimination in cases of organ dysfunction. Atracurium and cis-atracurium can be restricted for patients with organ dysfunction in a setting of limited supply, for example during contingency and crisis care surges. Conservation strategies for neuromuscular blockers in COVID-19 patients. COVID-19 patients develop respiratory failure in two different time-dependent patterns, type L and type H. In severe cases of respiratory failure, as frequently seen in SARS-CoV-related ARDS, severe hypoxemia can lead to a persistent increase in respiratory effort with consequent self-induced lung injury. In addition, other factors such as fluid overload or SARS-CoV-induced myocardial injury may also play important roles in worsening of condition through pulmonary congestion. The first respiratory failure pattern is type L, low elastance. This is respiratory failure with normal compliance that usually rapidly improves within the first 12 to 24 hours of positive pressure mechanical ventilation. These patients are unlikely to benefit from interventions such as neuromuscular blockers, as they often respond quickly to traditional mechanical ventilation strategies. Type H or high elastance. Some patients develop persistent moderate to severe ARDS despite optimization on mechanical ventilation. These patients likely require the use of rescue therapies for ARDS, including continuous infusions of neuromuscular blockers. For these patients, there are several strategies that can be utilized to conserve the supply of neuromuscular blockers. Do not start every patient on neuromuscular blockers if they have patient ventilator dysynchrony, as data for continuous infusion neuromuscular blockers are conflicting. A more conservative approach may be to initiate intermittent bolus doses of neuromuscular blockers initially to test if patient ventilator dysynchrony improves before initiating a continuous infusion. This is recommended by Surviving Sepsis Campaign COVID-19 guidelines prior to initiation of continuous infusions of neuromuscular blockers. If intermittent boluses are utilized, an intermediate-acting neuromuscular blocker with longer duration of action should be used, such as rocuronium, vecuronium, or pancuronium. If intermittent bolus doses of neuromuscular blockers are insufficient to control dysynchrony, or worsening hypoxia or hypercapnia occurs, then consider a continuous infusion of neuromuscular blocker for up to 48 hours. Consider removing depth of paralysis monitoring and BIS monitoring when utilizing continuous infusion neuromuscular blockade. When resources are limited, such as during crisis care, removal of these monitors can be considered. Studies for continuous infusions of neuromuscular blockers did not utilize TOF monitoring or BIS monitoring. Removing these monitors can reduce the use of personal protective equipment during the care of COVID-19 patients. Adequate supplies of these peripheral nerve stimulators and BIS monitors may be insufficient during resource limitations. In the absence of TOF monitoring, flat dose continuous infusion of neuromuscular blockers such as 37.5 mg per hour cis-atracurium used during the Accurasis or ROSE trials could be considered, and the rate increased or decreased based on clinical parameters, such as dysynchrony, plateau pressures, and driving pressures. In the absence of BIS monitoring while on continuous infusions of neuromuscular blockers, it is important to target deep sedation prior to initiation of neuromuscular blockers to avoid under-sedating patients, which can cause long-term mood disorders such as post-traumatic stress disorders. Flat-dose continuous infusions of neuromuscular blockers typically delivers more neuromuscular blocking agents than most patients require to improve desynchrony and oxygenation when using that rate, and may not be an effective drug conservation strategy. Consider titrating down or withholding continuous infusions of neuromuscular blockers at least once daily until desynchrony occurs. Nursing-driven clinical titration of neuromuscular blockers to patient ventilator desynchrony or plateau pressures exceeding 30 cm H2O may help conserve neuromuscular blockers. However, this strategy is not well validated and is outside of the nursing scope of practice. Consider this only during extreme resource limitations during the pandemic. These are my references. Thank you.